Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care. Happy Wednesday. Love to all the people here in LA, all the way through the Caribbean to Jamaica and Cuba. We want to send the highest heart love out to all of those. You are in our prayers. Let's pick up. Wow. Chapter 28 is where we pick up at on the clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel, Master Fitness Trainer. Thank you so much for being here for this new chapter book reading. Woo, we made it. We had the grocery giveaway today. It was wonderful. All right. Page 419. Those following along and in the replays on the playlist. Chapter 28. Clinical assessment of intrapulmonary shunt, oxygenation, and cardiac output. The placement of pulmonary artery catheters for monitoring left ventricular hemodynamic function in critically ill patients has become accepted clinical practice. Although the initial purpose for developing such catheters was primarily to monitor left heart filling pressures, their contribution to acute respiratory care has been notable since critically ill patient with a significant hypoxemia often presents a diagnostic challenge to ascertain the extent to which the cardiac and pulmonary systems are implicated. The exact pathophysiology is often in doubt despite careful clinical evaluation, including a detailed history and physical examination, routine laboratory studies, chest x-ray, and routine blood testing. Since a diagnosis determines the emphasis of treatment. Differentiation of a large primary intrapulmonary shunt from a primary myocardial dysfunction is often of critical importance. The Fick equation. Approximately 100 years ago, Adolf Fick described a procedure whereby the concentration of dissolved substance in the blood could be used as an indicator for determining blood flow. This concept became known as the Fick principle. When oxygen is used as the dissolved substance, the determination is known as the Fick equation. The quantity of oxygen potentially available for tissue consumption in a given unit of time is expressed as the arterial oxygen content, or CaO2, multiplied by the quantity of arterial blood presented to the tissues per unit time, or QT. So it goes oxygen availability equals QT times CaO2, 1. The quantity of oxygen returned to the lungs is expressed as the total cardiac output multiplied by the mixed venous oxygen content, or CVO2, obtained from pulmonary artery blood. Oxygen returned equals QT, and times CVO2, 2. Therefore, the tissue oxygen consumption in a given time interval, VO2, equals the oxygen that has been extracted from blood, i.e., the difference between the oxygen available, equation number 1, and oxygen returned, equation number 2. VO2 equals QT times CaO2 minus QT times CvO2. 3. Equation number 3 can be simplified and rewritten as follows. VO2 equals QT times CaO2 minus CvO2. 4. Equation number 4 is the Fick equation, which states simply that the oxygen consumed per unit time equals the oxygen extracted from the blood per unit time, deriving the Shunt equation. Rather than expressing the Fick equation as equation number 4, it is more commonly written as QT equals VO2 over CaO2 minus CvO2. Number 5. QT is cardiac output per unit time, L over minute. VO2 is oxygen consumption per unit time, cc per minute. And CaO2 minus CvO2 is the oxygen content difference between arterial and mixed venous blood volume percentage. As illustrated in figure 28.1, the total cardiac output, QT, is arbitrarily divided into two major components. QT equals QC plus QS. Number 6. QC is the portion of cardiac output that exchanges perfectly with alveolar air. QS is the portion of cardiac output that does not exchange at all with alveolar air. QS may be considered equivalent to absolute shunting, where shunt effect decrease V over Q exists, the blood will be incompletely oxygenated. Shunt effect is mathematically divided as though a portion of that blood exchanged perfectly, QC, and the remainder did not exchange at all, QS. Peace, YouTube. Thank you so much for being here. We're in a new chapter, chapter 28, page 420 down at the bottom. Those reading along in the playlist. I hope you had a wonderful day. So you could come into the peaceful part of YouTube and relax with us. So thank you for being here and reading books. Hi, it's Heart Love. All right, here we go. And the remainder did not exchange at all, QS. QC mathematically represents all the blood to which oxygen is being ideally added as it traverses the lung. The blood leaving these perfectly exchanging alveolar capillary AC units may theoretically be said to contain an in pulmonary capillary oxygen content, CCO2. This value is based on the assumption that complete equilibration between an alveolar gas tension and an end pulmonary capillary gas tension can exist in those AC units with capillary transit times within normal ranges, 0.3 to 0.7 second, and alveolar oxygen tensions, PaO2, greater than 100 millimeters Hg. The assumption is clinically valid. The calculated alveolar oxygen tension does not represent any real tension in the various alveoli, but rather an average value that is dependent on the physical laws of gas exchange and the respiratory exchange ratio. The mixed venous oxygen content, CvO2 represents the blood oxygen content being returned to the lungs. It can be measured only in pulmonary artery blood. The oxygen content of shunted blood QS is unchanged from the mixed venous oxygen content. Therefore, instead of equation number 4, the organism's oxygen consumption may be derived from an expression written as equation number 7. VO2 equals QC, then CCO2 minus CVO2, number 7. Therefore, QT and then brackets, CaO2 minus CvO2 and bracket equals QC bracket CCO2 minus CvO2 and bracket. Number 8, the physiologic shunt equation expresses the relationship between total cardiac output and shunted cardiac output. Therefore, equation number 6 is solved in terms of QC. QC equals QT minus QS. Substituting equation number 9 for QC in equation number 8 results in the following equation. QT and then CoAO2 minus CvO2 and bracket equals bracket QT minus QS bracket CCO2 minus CvO2 and bracket. Number 10, expanding equation. Number 10, algebraically. QT-CaO2 minus QT-CvO2 equals QT-CCO2 minus QT-CvO2 minus QS-CCO2 plus QS-CvO2. Number 11, note that the 2 of the 6 terms, QT-CvO2, are identical and common to both sides of the equation, and therefore may be removed from the equation. The collection and factoring of all QS terms on the left side and all QT terms on the right side of the equation results in QS bracket CCO2 minus CvO2 bracket and bracket equals QT bracket CCO2 minus CaO2 and bracket. Number 12, this relationship can now be written as a ratio of shunted cardiac output to total cardiac output. QS over QT equals CCO2 minus CaO2 over CCO2 minus CvO2. Number 13. All right. Equation number 13 is the classic shunt equation. It has the advantage of being derived as a ratio so that no absolute measurement of cardiac output is required. In this form, the equation very clearly demonstrates that as the shunted cardiac output QS approaches 0, the arterial oxygen content must approach the theoretic value of end pulmonary capillary oxygen content. As long as a portion of the cardiac output exists as shunted blood, the arterial oxygen content will always be less than the end pulmonary capillary oxygen content. In other words, since shunted blood has the same oxygen content as mixed venous blood, CvO2, when this blood mixes with the perfectly exchanging cardiac output, QC, a lowered oxygen content equilibrium, CaO2, must be established. This may be conceptualized as oxygen leaving the QC hemoglobin and attaching to previously desaturated QS hemoglobin. The end result is always the arterial oxygen content somewhere between the end pulmonary capillary oxygen content and the mixed venous oxygen content. Woo! Woo! Here we go. At the top of page 422, figure 28.1. So what we're looking at is the physiologic shunting and the QT, cardiac output per unit time, right? It says figure 28.1, mathematical concept of physiologic shunting. QT is cardiac output per unit time. QC is the portion of the cardiac output that exchanges perfectly with the alveolar air. QS is the portion of the cardiac output that does not exchange with alveolar air. PaO2 is the alveolar oxygen tension. And this is from Shapiro, B.A. Harrison, R.A., and Walton, J.R., Clinical Application Blood Gases, second edition, Chicago Yearbook Medical Publishers, 1977. All right, here we go. So what you'll see is showing the right atrium and right ventricle, the pulmonary artery, the QS, capillary shunt unit, anatomic shunt, a perfect exchange unit, pulmonary veins, left atrium, and left ventricle down at the bottom. So you'll see the right atrium and right ventricle is at the top. All right. Thank you so much for reading books with us. Eyes, Heart, Love, clinical application of respiratory care. And we are in the 28th chapter, the first reading from the 28th chapter. This is by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, second edition, Yearbook Medical Publishers. All right. Clinical shunt measurement. Peace, YouTube. Eyes, Heart, Love. Welcome. Thank you so much for reading books with us, all the book lovers community, everyone. This is the peaceful part of YouTube where we read books, learn from masters, and we like to give reverence and love to our family, our friends, our ancestors. And right now we're sending big prayers, big love to the Caribbean and Jamaica, Cuba, and everyone out there going through this Hurricane Melissa. Eyes, Heart, Love. We're praying for you. Bottom of page 422. Clinical shunt measurement. The intrapulmonary shunt can be calculated whenever both systemic arterial and pulmonary arterial blood gases are performed. The CCO2 is calculated by assuming that the in-pulmonary capillary hemoglobin content is the same as arterial and by calculating the alveolar PO2 by the alveolar gas equation. Clinical intrapulmonary shunt measurements should be done at the patient's maintenance, FiO2. It is not necessary to place the patient on 100% oxygen for the measurement. In fact, 100% oxygen inspired often increases the shunt. Total oxygen consumption. Oxygen consumption can be readily measured in cooperative patients' breathing room air. However, it is not readily measurable in the critically ill patient, although the mass spectrometer shows promise of being able to provide serial oxygen consumption measurements in the critically ill patient. At present, the technique is not widely available. However, when cardiac output and arterial venous oxygen content difference are measured, the oxygen consumption can be calculated from the Fick equation. In most clinical situations, the following general statement is valid. In a patient who is adequately perfused, normothermic, and not shivering or seizing, the metabolic oxygen demands are reasonably normal and can be represented by a value of 3.5 milliliters O2 over kg of normal body weight. If any of the criteria are not met, This manner of approximating oxygen consumption cannot be reliably assumed. Arterial venous oxygen content difference. Middle of page 423. The arterial oxygen content minus the mixed venous oxygen content difference, CaO2 minus CvO2, represents an assessment of the cardiac output in relation to the metabolic rate. This becomes obvious when the arterial mixed venous oxygen content difference is considered in the content of the Fick equation, equation number 4. Under conditions in which the oxygen consumption, VO2, remains constant, changes in the cardiac output, QT, can be related to changes in arterial mixed venous oxygen content difference, CaO2 minus CvO2. In other words, as cardiac output increases under these circumstances, oxygen extraction per unit volume of oxygen of blood decreases. Table 28.1. Although normal AV content difference is 4.5 to 6 volumes percentage in the critically ill patient with a competent cardiac reserve. The AV content difference is approximately 3.5 volume percentage. Table 28.2 lists reference values relating to pulmonary artery blood gas samples and the derived values. As stated previously, clinical application of these values also requires simultaneous measurement of an arterial blood gas. These values should be considered only as guidelines, and they assume a normal oxygen carrying capacity, clinical evidence of adequate peripheral perfusion, adequate alveolar ventilation, and a normal acid base status with the patient either breathing spontaneously or being supported on the ventilator. When factors such as severe anemia, lack of peripheral perfusion, severe hypercarbia, and acidemia are superimposed, these guidelines begin to lose their clinical usefulness. These physiologic measurements should be used as early warning indicators of impending or early cardiovascular decompensation. Their clinical value lies in the fact that changes in pulmonary artery blood gases secondary to cardiopulmonary stress often occur earlier than changes in systemic arterial blood gases. This allows for initiation of corrective therapeutic maneuvers, reversing the pathophysiology at an earlier stage. In patients who meet the criteria for assuming that oxygen utilization is consistent, changes in AV content differ- difference may be interpreted as correlating with changes in cardiac output. Here's the table 28.1 relationship of cardiac output to oxygen extraction. All right. So it shows the condition, normal cardiac output, increased cardiac output, and decreased cardiac output. And then oxygen consumption, cc per minute, 250, 250, 250. Cardiac output QT in liters, L per minute, 5, then 10, and then 2.5. And oxygen extraction, CaO2 minus CvO2, volume percentage, and cc over liters, 5, 50, and then 2.5, 25, and then 10, 100. All right, so this is table 28.1 relationship of cardiac output to oxygen extraction. Thank you so much for reading the books with us. Eyes on. There you go. Table 28.1. We're in the 28th chapter of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. There we go. Thermodilution cardiac output measurements. A triple channel pulmonary artery catheter contains a second fluid filled channel that ends approximately 30 centimeters from the tip of the catheter. This opening is designed to lie in the right atrium or superior vena cava and is used as a CVP monitor. So here's table 28.2, predicted blood gas values in health and disease for pulmonary artery blood. This is deep because we're going to the range and average, range, average, range, average. For the PVO2, for the percentage HB saturation, and then the CaO2 minus CVO2, volume percentage, range and average, all right? And this is the condition. So all to the far side, you have the healthy resting human volunteer, and then critically ill, the healthy resting human volunteer critically ill. Then patient cardiovascular reserves excellent, critically ill. Then patient cardiovascular stable, limited cardiovascular reserves, critically ill. Patient cardiovascular decompensation. All right. So range is for the healthy resting human volunteer 37 to 43, and the average is 40. Range percentage is 70 to 76, and average is 75. The range for the CaO2, CVO2 is 4.5 to 6.0. The average is 5.0. Next is 35 to 40 in range PVO2. Average is 37. Range percentage in HB saturation is 68 to 75. Average is 70. Range for CaO2, CVO2 minus CVO2 in the patient cardiovascular reserves is 2.5 to 4.5. Average is 3.5. And then in this the patient cardiovascular stable limited cardiovascular reserves is 30 to 35 in the PVO2, and the average is 32. The range percentage in HB sat is 56 to 68. Average is 60, and the range for the CaO2 minus CVO2 volume percentage is 4.5 minus or to 6.0, and the average is 5.0. And last but not least, and critically ill patient cardiovascular decompensation is less than 30, less than 30, less than 56, less than 56, less than 6.0, and less than, and then, greater than 6.0 and greater than 6.0. All right, woof, that's table 28.2 down here at the bottom. All those following along and reading and playlist along with us. There you go. See that? It's what we just read in Clinical Application of Respiratory Care. We are now in the 28th chapter. All right. And then we have on page 425 says the 4-channel pulmonary artery catheter. This is figure 28.2. The distal channel and balloon channel comprise the basic 2-channel catheter. Addition of the proximal channel that opens in the right atrium results in triple channel catheter, usually 7 French in diameter. Addition of the thermometer channel results in a 4-channel catheter used for the thermal dilution cardiac output measurements, usually 7 French in diameter. Okay. So you'll see the balloon channel, the proximal channel, the distal channel, and the electrical connection for the thermistor. And over here you have the distal opening and proximal opening. Top of page 425 in the 28th chapter. Thank you so much for reading with us. Highest heart love. Love to all the book lovers community, all my mods. Thank you so much, all my friends and family. The 4-channel pulmonary artery catheter, figure 22, has a thermistor at the end of the catheter. Cardiac output can be calculated by knowing the amount of cold injected and the average temperature change, concentration of cold, during the time required for total injection of the cold solution from the right ventricle. In reality, this technique represents an application of the basic Fick principle. The quantity of cold injected representing the solute replaces the term oxygen consumption. VO2, right? And the average measured temperature change in the pulmonary artery blood replaces the arterial mixed venous oxygen content difference, CaO2 minus the CvO2 in the Fick equation. Tissue oxygenation. The diffusion of oxygen from the blood to tissue depends primarily on the oxygen pressure gradient between capillary blood and tissue. The lower the capillary oxygen tension, the less the potential for oxygen diffusion. Hemoglobin oxygen affinity. A factor of paramount importance to tissue oxygenation is the strength with which hemoglobin chemically combines with oxygen. This chemically bound oxyhemoglobin is intimately related to the PO2, but does not itself exert a partial pressure. This is good, right? Happy Wednesday. What a treat. What a treat. Right? Oh, man. So beautiful. Because nearly all oxygen in the blood exists in chemical combination with hemoglobin, almost all the oxygen molecules that diffuse to tissue must first break their chemical bond with hemoglobin. Ding! So beautiful. You know, when plasma, how they extract the plasma is the blood goes through this long cord and then it separates the molecules through a centrifuge, right? This is how we identify the plasma from just the hemoglobin. This is very key. All right. Bulk flow of oxygen to tissues requires the dissolution of oxygen binding with hemoglobin. The strength with which the hemoglobin chemically binds the oxygen is referred to as hemoglobin oxygen affinity. This affinity is affected by such factors as hydrogen ion concentrations, carbon dioxide content, and temperature. An increase in these factors decreases the hemoglobin oxygen affinity, i.e., shifts the curve to the right. See figure 6.4. Phosphorylase enzyme systems within the red blood cell are also known to affect the affinity. The theoretic significance of an increased hemoglobin oxygen affinity is that any pressure gradient will transfer fewer oxygen molecules per unit time. Each of the four iron binding sites in the hemoglobin molecule is affected by the oxygenation status of the other three sites. As each successive hemi iron moiety is occupied by oxygen, the distance between them is decreased. These spatial relationships are believed to significantly affect the ability of the unoxygenated heme moieties, moieties to combine with oxygen. This physiochemical relationship is probably the basis for the sigmoid shape of the hemoglobin dissociation curve. When normal blood is 75% saturated, the vast majority of hemoglobin molecules have three oxygenated hemi sites, and when 50% saturated, have two oxygenated hemi sites. It may be inferred that removal of oxygen from the hemoglobin becomes progressively more difficult as the blood falls below 75% and then 50% saturation. Normal tissue oxygenation demands only oxygen from the fourth hemi site, since normal PVO2 is 40 millimeters Hg, 75% saturation. See figure 6.2. A venous oxygen tension represents the lowest possible oxygen tension existing in the capillary bed. Therefore, when PVO2 falls below 27 millimeters Hg, it may be inferred that oxygen must leave hemoglobin that is less than 50% saturated in order to meet tissue oxygen demands. Clinical assessment of PVO2. In the presence of normal hemoglobin values, the existence of tissue hypoxia must be considered when PVO2 falls below 27 millimeters Hg. For example, a PVO2 of 20 millimeters Hg can mean either 1. Tissue oxygen needs are being met through significant desaturation of hemoglobin, or 2. Further desaturation is not possible and tissue oxygen needs are not being met. In a patient with normal hemoglobin and adequate perfusion, a PVO2 above 30 millimeters Hg almost always ensures that tissue oxygen needs are being met. Summary. Thank you so much for the likes and subs. We're pushing towards 600 subs on this peaceful part of YouTube where we read books and learn from masters. Hi, it's Heart Love. Peace, Annette. Hi, it's Heart Love. Thank you so much. She's like, oh, you read books on YouTube. I was like, yes. So thank you so much for being here and subbing. It's another way we give back to our community. We uplift the community and being positive and showing them that they can, you can, is a big part of doing that, right? So this is the reading part. It's the peaceful part of YouTube where we read books and learn from masters. So high is heart love, gratitude. Summary, page 427. The development of the balloon-tipped pulmonary artery catheter has made pulmonary artery measurements available at the bedside of the critically ill patient. Besides hemodynamic monitoring, blood gas measurements of true mixed venous blood values, in conjunction with arterial blood gas values, have allowed the clinician to identify more clearly the cardiopulmonary pathophysiology and have further reinforced the interdependence of the two systems. We completed another chapter on one read. Yes, YouTube! Completion of chapter 8. 28. Completion of chapter 28. Thank you so much. Highest heart love. Thank you. Like it. So we did it. Reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We just completed the 28th chapter as well as section 7. Section 7 is completed and we are now moving into section number 8 of this beautiful, masterful book. When we reconvene, Section 8, Common Pulmonary Pathology in Acute Respiratory Care. So thank you so much for being here and reading with us. Again, love and honor to all our friends and family, all the book lovers community. Highest heart love. We love you so much. Live here from the light here in LA. So we did the grocery giveaway today. 289. 289 weeks giving away groceries to the people, and now it's needed more than ever, right? So we're playing our part. This is the part of YouTube where we're playing our part again, reading to the people. We have to keep boosting our vocabulary. That's a part of our expansion. So part of our legacy and being, do we show love? Are we building? Or are we destroying and hating things? See, because love grows life. Anything with life. Love grows care. And so this is respiratory care. So we're going to have a drink of love water. Thank you so much for going through a whole chapter with us in this book reading. Highest heart love. Thank you so much. Oh, highest heart love. Said peace, King. Thank you so much. Here we go. Live from the light. I love you. Love water to the people. Sending prayers and honor to all our friends and families in the Caribbean, Jamaica, and Cuba. We ask that you protect the rest that have made it through this far. We ask that you shine light. Give them comfort in the night. Highest heart and honor. Mm, mm. Love you. I love you. I love you. I love you. Thank you so much for being here and reading books with us. Love to all the book lovers community. Highest heart love. Thank you so much, Piero. Mark Redfield has elevated as well. So I'm going to take a deep breath. Love and honor, South LA Cafe, all our friends and family. Mark Redfield, great actor and mentor to so many. Thank you so much for shining your light, all you've done for all the people. Another light worker, Gage, at our side. I love you. I love you. No, because I love myself. Love to all the light workers. Highest heart love. I'll see you when we reconvene. Moving into the next chapter, chapter 29. I'll see you soon.